right. Good morning, everybody. I'm really excited to get to introduce to you this morning my friend and former colleague, Dr. Ganesha Kaur. She insists that she's used to this weather because she's from Buffalo, because it's really cold, right, guys? But she went to undergrad at Cornell, medical school at Cornell, residency at Cornell, fellowship at Harvard. So that was a little bit of a change there. She has her master's in medical anthropology. She has started the Global Health Fellowship at Cornell. I really got to take advantage of that while I was there and take a trip to northern India. She's the director now of the Global Health Initiative and does a lot of work on human rights, which got her into the global health field. And she has had her work funded by Fair Grants and just recently got a K Award to study the evaluation of chronic pain in refugees. So I'm really excited to have her here, and she's going to talk about all the different things she's doing right now. And I think it's an exciting opportunity for us to think about what we're about to embark upon here at our own institution.
Good morning, everybody. Thanks for that intro. I really do love this weather. It's probably very odd. So my goal today is to give you an overview of global health, human rights, and how anesthesiologists can make an impact. I have no conflicts. Funding disclosures, I was funded by FAIR and now the NIH, as Angie mentioned. The goal of today is really to get an understanding of the major players in global health and human rights work and what role and opportunities anesthesiologists might have. The language has really shifted from international health to global health. International health implies that these are problems of other countries, whereas global health more accurately describes issues as transnational in nature. So the concept of global health rejects the idea of the first, second, and third world in favor of an acknowledgement that we're all part of one humanity. So these are pretty big learning objectives, and we'll just get started. Over the past decade, there's been a significant rise in interest in global health among trainees in medical school, residency, and even at the faculty level. People are interested in getting involved in work in the developing world, and the medical community is deeming this so important that leaders in medical and graduate medical education, such as the AMA, have recommended that global and public health training be a core competency. The study at the top, conducted by the University of Pennsylvania, their anesthesiology department, demonstrates that 91% of 460 participants indicated their interest in global health opportunities, and almost 80% of medical students said that the availability of a global health outreach track would influence their program ranking for residency. So residency programs are really being challenged to match such interest with educational programming, but a study by my group found that standardized, validated curricula developed by anesthesiologists with specialty training in global health are unavailable. Our specialty has really not invested in global health as a serious academic field, and the result has been that the approaches are pretty haphazard. Unlike cardiac, regional, or ICU, global health has really been sort of neglected. It ends up being a hobby that people take on at the side, and other specialties like surgeons and obstetricians have really stepped into the space that's been left through our absence and have taken leadership roles in global surgery, research, education and training, and implementation programming. So for this talk, I'm going to cover three major themes. The first being the Lancet Commission on Global Surgery and taking a look at what's really being done in this sphere, mostly by surgeons. A few years ago, surgeons realized that there was a gap between the need for and the availability of surgery and anesthesia worldwide, and that this was really a major global and public health problem. So they approached the editors of The Lancet, and they decided to address this gap. And so from there was born the Lancet Commission on Global Surgery, from 3 surgical co-chairs from these universities and 22 commissioners. Now, this group is mostly surgeons. There are some economists, public health experts, and 1 anesthesiologist. So, the research and implementation programming agenda is really being set by non-anesthesiologists. What the commission decided to look at was 3 procedures. They took cesarean delivery, laparotomy, and open fracture repairs. And they used this as a measure of surgical system strength and capacity. These 3 procedures require skills, obviously, that span surgery, OB, and anesthesia. So the assumption here was that if a system could provide these 3 procedures, they're likely capable of providing other critical core vital procedures like appendectomies, hernia repairs, INDs. And for this reason, these 3 procedures were termed the bellwether procedures. The commission started to investigate how available these procedures are across the world. And what they found was the following. 5 billion people lack access to safe, affordable surgery and anesthesia care when needed. So that's 70% of the world's population. Access is worst in low and lower middle income countries where 9 out of 10 people can't access basic surgical care. So this map from the Lancet report describes the proportion of people without access to surgery. And you can see in much of the world, almost 100% of people don't have access to life-saving surgery when they need it. The commission found that of all the procedures that happen worldwide, only 6% occur in the poorest countries, where over 1/3 of the world's population lives. And even when surgery and anesthesia do happen, morbidity and mortality is very high for simple procedures like hernia repairs. The commission found that 30% of the global burden of disease can be attributed to surgically treatable conditions. And they estimated that 143 million additional surgical procedures are needed. In some parts of the world, as you can see, like North America or Eastern Europe, there's little unmet surgical need. But in places such as South Asia or Sub-Saharan Africa, the gap between the need and the availability of care is pretty enormous. So the commission set out to understand why there is this gap. And what they determined was a 3 delays framework. The first delay is delay in seeking care. So this happens when patients wait to see a healthcare provider because of cultural beliefs, education, economic constraints, just a lack of confidence in providers. Instead, they go to traditional healers because they're accessible, they're trusted, and they're inexpensive. An example of the first delay would be people who do not seek surgery or anesthesia because they just can't afford to pay for it. Nearly half of the world's population lives in poverty, which is defined by the World Bank somewhere between $1.90 and $2.50 a day. So think about what you spend $1.90 a day on: a bottle of water, a cup of coffee. Half of the world's population lives on less than that per day. And so for many people, it's just too costly to access care. Even if it means that a member of their family loses their life, they just cannot afford to pay for surgery and anesthesia. It's not just the financial impact of the surgery itself, but the financial restriction and consequences of missing days of work or postoperative care. The commission estimated that 1 in 4 people around the globe who do receive surgery and anesthesia will face catastrophic expenditure, and so they will be economically crippled going forward. And this is something that we know. There's no question that poverty plays a huge role in health. This graph by Gapminder, as you can see, demonstrates the correlation between income and health. Now, it's not a perfect graph. It doesn't filter for all the confounding factors, but you can see, obviously, there's a correlation between income and health here. Another reason for the first delay is expectations. This map documents healthy life expectancy at birth, so essentially how long people expect to live a healthy life based on where they're from. In Canada, for example, you can see that life expectancy is 70 to 75 years, whereas somewhere like Somalia, it's closer to 50 years. And this map sort of gets to one of the reasons for the first delay. In the US, we go into a hospital for a fracture repair or an appendectomy, and we expect to come out alive. You expect all of your patients to survive surgery. But in the developing world, that's just not how people understand the hospital system. They expect to go to the hospital and maybe come out alive and maybe not come out alive. And so people avoid engaging with the healthcare system. And there's a very low confidence in the system and in providers, and it's rooted in real experience. This study by Paul Greeno at Harvard discusses coercive vaccination schemes in India that led to a mistrust of healthcare providers. So he describes how during a WHO campaign to eradicate smallpox, healthcare workers, especially foreign healthcare workers, would break down doors of people's homes, chase them, hold them down, forcibly vaccinate them. And while that had great success in eradicating smallpox over a generation, it really ingrained deep fear of healthcare providers. And this is not a unique experience. Over 80% of people in low-income countries report being the victim of healthcare-related corruption, such as bribes for healthcare tasks. So it's really not surprising that people in the developing world want to avoid going to a hospital system. The second delay is the delay in actually reaching care. So when the nearest facility is hours or days away, depending on what the mode of transportation is. When people have to travel 3, 4, or 5 hours to the nearest hospital by foot or carriage, for example, that's a really big barrier to healthcare, particularly when the train is rough or they don't have enough money to pay for that travel. And the final delay is a delay in actually receiving care. So somebody says, I'm gonna go to the hospital, they get their stuff together, they travel for a day, they arrive at a facility, and then there's no resources there. There's no providers, or there's no ability for those providers to perform surgery or anesthesia. Looking specifically at African nations, 55% of district hospitals have no anesthesia machine. 70% of ORs have no pulse oximeter. I wouldn't feel comfortable performing anesthesia without pulse oximeter. 70% of ORs didn't have a pulse oximeter. 35% of hospitals in Zambia, for example, had no laryngoscope. So somebody gets to the hospital and they just can't access care. The third delay, in part, is related to a sheer lack of surgeons, anesthesiologists, and obstetricians. As you can see here, there's just a gross maldistribution of access to care. Some countries, like Norway, have 100 physicians per 100,000 population, whereas in places like Rwanda or Somalia, there's less than 1 physician per 100,000 individuals. The cost of filling this need of surgeons, OBs, and anesthesiologists, along with the cost of creating the actual infrastructure to support them, was calculated somewhere between $300 and $550 billion. But this is compensated by a potential increase in income of $20.7 trillion to the global economy by decreased morbidity and mortality related to surgical conditions. This raw gain, or loss, depending on how you see it, has a huge impact on GDP. Looking at this graph here, you can see that surgical conditions have the potential to reduce annual GDP growth by nearly 2%. So investment in surgical healthcare infrastructure not only leads to increased life expectancy, but also to a rise in national income. In assessing priorities for global health, experts looked at this. They investigated what the return on investment was, and they used a measurement of overall disease burden, or daily values, disability-adjusted life years, which is the number of years lost not just to death, but to ill health or disability. So in this example, you can see Zimbabwe has one of the highest daily values at more than 80,000 life years lost out of 100,000 life years, whereas somewhere like the United States or Canada has fewer than 10,000 life years lost out of 100,000 due to disability or death. In 2010, the World Bank assessed cost effectiveness of investing in global surgery and anesthesia and compared it to other public health interventions, specifically looking at those daily values. And what they found was that 16.9 million lives, or 33% of all deaths worldwide, were lost from conditions needing surgical care. And compared to this, the number of deaths related to HIV, tuberculosis, or malaria combined, which is really where the greatest investment in global health is, equaled 2.87 million lives. And so this indicates to us that investing in surgical conditions and the treatment of those conditions might be very cost effective. Similarly, the Lancet Commission compared the cost of various global surgery and anesthesia interventions per daily averted to other interventions. And they found that global surgery and anesthesia was, in fact, a very wise financial investment, as you can see here. So, for example, general surgery gives a far higher ROI than aspirin or beta blockers for ischemic heart disease. You could see male circumcision, in another example, is really high yield compared to the cost of ART for HIV. Up until now, because surgery and anesthesia is seen as so complex, requiring huge investment in infrastructure, think about your ORs, how many individuals it requires to actually have one successful procedure happen, it was really thought as being too complex for resource-poor settings. But the major takeaway from this set of slides is that there's a giant gap in access to global surgery and anesthesia, and investing in surgical services in lower and middle income countries saves lives, promotes economic growth, and is really affordable. Also, thinking about treatment like ART for HIV is sort of a single shot treatment. But investing in surgery and anesthesia builds infrastructure. It builds systems to really grow a healthcare community. And so it's sort of a doubly useful intervention. Even if you never plan on going abroad, you're not interested in global health, you don't think this is relevant, this information really should be of interest because a chunk of federal funding from the US is going towards such programs. You can see that somewhere between $9 and $10 billion is being spent on global health. Part of the reason for this investment is that global health ultimately turns into an issue of national security. So when we look at the spread of tuberculosis or HIV, Zika, or Ebola, these turn into national security issues. And so that's why you see divisions like the DoD funding global health work. Of the federal funding we see here, no substantial amount is spent on global surgery and anesthesia. So one of the questions is, if funding is going to be spent on global health, how do we ensure that some of it comes to us, that some of it comes to global surgery and anesthesia? And I'll break this down first by looking at the major mechanisms by which anesthesiologists participate in global health and human rights work. As you probably know, one of the major ways that global health is practiced by anesthesiologists is through medical missions, volunteering with NGOs, and participating during emergency disaster situations. And we'll tackle each of these briefly next. Medical mission trips often involve traveling from developed to developing countries, spending a few weeks or months participating either in surgical or anesthesia care like cleft lip, repairs, cataract surgeries, or teaching advanced skills to local providers. Medical missions can provide a lot of care to communities where there's a lack of providers or a lack of education, but global and public health experts over the past few decades have really challenged the value of these interventions because of the problematic nature, potentially, of foreign providers in country. This is not to say that all medical mission work is bad, but just that we have to be really thoughtful about what we're doing when we go abroad. Some of the problems are, for example, trainees performing work that they would not be able to do unsupervised at home, inadequate preoperative or postoperative management of patients, unintentionally challenging local healthcare infrastructure or local healthcare workers, how they're seen by the local community once foreign providers leave, and then obviously context-insensitive teaching. This is a graph by my group a very talented graphic designer in my team, we looked at where medical missions go and where the countries of greatest need are located, as determined by World Bank poverty and health indicators. And as you can see, study abroad programs from undergraduate to medical to postgraduate education typically take place in more affluent or middle income settings. So people will go to South Africa rather than going to Burundi. They'll go to Brazil rather than going to Haiti. Recently, during an elective that we did in East Africa, my team encountered a team of providers, a group of cardiothoracic providers in country, and this was a group of 60 people that were doing 16 surgeries over 7 days. And they brought in this huge team and set up, preoperative clinic and a step-down unit and an ICU, hundreds of thousands of dollars. And what they were doing was double or triple valve repairs for rheumatic heart disease. And my team was looking at this, and we were a little bit horrified. They were doing these valve replacements on 17, 18, 19-year-old girls who were going to be on lifelong anticoagulation, who were expected culturally to have 4, 5, 6 kids. As neonatal mortality rates go up, people have more children. And we were thinking to ourselves, this is such an expensive investment. What would it look like if instead of doing these 16 surgeries, they took all that money, hundreds of thousands of dollars, and just invested it in rheumatic heart disease prevention? Who would that benefit? How many more people would that benefit? And that's not to say that medical missions are bad, but that we just have to be really thoughtful about what we're doing. Out of cases like this was born the idea of the unintended consequences of purposive social action. And I'll give you an example that's directly related to anesthesiology. This was really sort of an excuse to get some photos of Angie up here. But one of the major ways that anesthesiologists have been participating in global health is to teach advanced ultrasound skills to providers in the developing world, both for peripheral nerve blocks and also vascular access. So this is a photo of our team in 2015 in India. Before our group goes abroad, we really educate them about the local context. We teach them about what it means to teach ultrasound to other providers, but we know that not all providers get such a rigorous education before they go abroad. And the reason this is important is because the social context in India and in many countries in the developing world is where violence against women takes the shape of domestic violence, bride burnings, dowry deaths, and most significantly, female feticide through the practice of ultrasound use. In India, it's really related to economics. So the cost of women is extremely high because families have to pay for wedding and dowry expenses. The average wedding in India cost 35,000 rupees, and the average civil servant makes 3,500 rupees, so they'd have to save for 10 years to marry off one girl. And so they just cannot afford the cost of girls. And they've really turned to female feticide facilitated through the use of ultrasound. This is an extremely prevalent practice resulting in skewed gender ratios, and that's what's shown in this first graph from The Economist. The second graph shows the diminished likelihood of having a girl child after one girl child has been born into a household. And as you can see, this implies female feticide, and studies have shown the direct correlation between ultrasound use and female feticide rates. So just being thoughtful about going abroad, understanding the local context and what it means to teach ultrasound in this context, and how can you do that responsibly. After medical missions, the second major way that anesthesiologists participate in global health is through NGOs, such as the Red Cross or MSF. MSF has a really interesting history. It was born out of conflict in Biafra in Nigeria. So in 1968, the southern province of Nigeria, which is Biafra, seceded, and people were really decimated by war and famine. And at that time, the only organization that was going into conflict zones was the International Federation of the Red Cross. And there were three French physicians who joined the ICRC in Nigeria. And they found themselves providing surgery in a context where the hospital was constantly being attacked by Nigerian armed forces that was backed by the government. And they felt like they had to speak out about this and tell the international community what was happening. But the ICRC takes a very strong position on neutrality and impartiality. And they said, you can't tell anybody what's going on, you're just providing care. And so these French physicians decided to create a separate organization, which became MSF. MSF takes the view that if something egregious is happening, if children are being abducted, if civilians are being murdered, that they will speak out against it and any hindrances to medical care, which is an amazing mission, but it's also the reason why they're targeted more frequently in violent conflict than other healthcare organizations, because they speak out against political, economic, or religious barriers to healthcare. In contrast to this, Red Cross and Red Crescent societies work in total impartiality and silence. They believe that this is the only way that you can actually provide humanitarian protection and assistance for victims in armed conflict. Famously, for example, in the Holocaust, the ICRC was actually present in concentration camps and in ghettos, and they did not publicly condemn the atrocities. They didn't petition the German government to respect human rights, because they felt that if they did, they would be blocked from providing care to people who really needed it. Out of curiosity, I always like to ask this question because it's interesting to me. If you had to pick between MSF and the Red Cross, who would you volunteer for? Just a show of hands, who would volunteer for the Red Cross? Okay, MSF. That's a very different spread. So normally it's split 50-50, so it's pretty impressive. Most people would volunteer for MSF. The third and final major way that anesthesiologists engage with global health is through humanitarian disasters. And we play an absolutely critical role here, from running mobile intensive care units to providing necessary surgical and obstetric support to ensuring perioperative quality and safety. We know that without anesthesia providers, it's really well documented that surgeries just don't happen safely. In the 2010 earthquake in Haiti, for example, amputations, they had such a need for amputations, and a lot of them happened just without any analgesia. The surgeons just went in and took off limbs. And, there's pretty grotesque descriptions of that in popular media, in CNN, BBC. Humanitarian emergencies are one really great example of how all physicians should be trained in global health. We just don't know where the next natural disaster, earthquake, tsunami, or flood is going to be. And especially with the transnational spread of disease, it's really important for all healthcare providers to at least have a basic understanding of global health. So Zika and Ebola are a couple of cases that we'll get into just very briefly. If you think that Zika is not relevant to you because you're not a young woman of childbearing age, that's not correct. Zika not only causes pregnancy complications like microcephaly and Guillain-Barré disease, but recently researchers at Rockefeller University demonstrated that Zika leads to loss of neuronal progenitor cells, resulting in a disease that's very similar to Alzheimer's. So this is something that should be relevant to all of us as healthcare providers. The 2015 West African Ebola outbreak is just another great example of the relevance of global health to all providers. There have been several Ebola outbreaks throughout Africa. There's one in Democratic Republic of the Congo right now. This was special for a few reasons. Ebola was so devastating in this region in West Africa because the countries that it hit, Guinea, Sierra Leone, and Liberia, had some of the lowest investment in public health infrastructure throughout all of Africa. And containment was very, very challenging. And that's why people started to really care about it, because it started to spread from West Africa to Europe and to the United States. And it's really a great example of how acute crises challenge the existing healthcare system and expose weaknesses. This outbreak really crippled an already weak economy and devastated the healthcare infrastructure there. Anesthesiologists played a very critical role during this outbreak in mobile intensive care units and resuscitation. But we were really not prepared. We didn't know how to do that. We didn't know how to deal with Ebola if it should come to our departments. In New York, there was sort of mass panic because there was one person who was riding a subway who had been potentially exposed, and our hospital people were really worried about how to deal with Ebola patients, how to intubate these patients while protecting our staff. The last bit that I'll get into is what we do at Cornell. We've really decided to accept that global health is coming to us and take on this challenge and make it a very serious academic field. At Cornell, we focus on refugees, migrants, and asylum seekers, which we believe is sort of the cutting edge of medicine and what we'll all have to deal with pretty soon. Our goal is really to bring global health back to the US. So it's not just about the people that go abroad, but it's about treating healthcare providers how to deal with foreign-born patients that are coming to us. Given the acceleration of violent global conflict, it's more and more likely that you're going to encounter a refugee, a migrant, or an asylum seeker in your practice. The US carries only about 5% of the global refugee burden, and we know that somewhere between 5 and 60% of refugees are torture survivors. In urban healthcare centers, there have been some studies that have looked at the population of torture survivors or asylum seekers, and it's about 10 to 15%. So your chances of encountering a refugee or asylee are pretty high and are increasing. Let's just take a few minutes to understand where these people are coming from and why they're coming. The WHO has declared the current refugee migration the worst humanitarian crisis since the Second World War. Refugees are often very highly educated. These are not people that come homeless. These are people who are often doctors, lawyers, engineers. They really do not want to leave their home countries. There was a great CNN article recently talking about why refugee doctors become taxi drivers. Nobody wants to make that transition, but these are people who are fleeing war, persecution, violence. There's 65.3 million displaced people worldwide, which is greater than the population of France. There's 21.3 million refugees, and I think what's really striking about that bottom figure is that there are double the number of internally displaced individuals. So IDPs and refugees are almost identical. IDPs just don't cross an international boundary, so they're not protected by international human rights and humanitarian law. And the proportion of asylum seekers is actually pretty small, so 3.2 million asylum seekers. This is a map looking just at refugee origin, and as you can see, though it's a pretty diffuse spread, people are really coming from a few concentrated areas. The world's refugees are currently coming from Syria, Afghanistan, and Somalia. And these areas alone account for more than 50% of refugees worldwide. Some of this is really chronic, like in Afghanistan, and some of it is pretty acute based on where local conflict is happening. We know that over 50% of refugees are children under the age of 18. That's a really striking figure. Think about the economic, social, health implications of over 30 million children fleeing their home countries. It's pretty astronomical. We know that most of the displaced men, women, and children worldwide are actually going to developing regions. So 86% of people are being hosted in developing regions, which is really incredible. I find that a little bit embarrassing for developed regions. And I think the figure on the right here is a really beautiful depiction of the top 5 countries of refugee origin and where they're going. And what you'll notice, for the most part, the other category, that teeny tiny little slice, that's the United States, Canada, and Western Europe. So for all the talk of refugees and asylum seekers coming to the US, we're really supporting a very small proportion of global refugees. Asylum seekers are refugees who have applied for legal status in a country, and unlike refugees, they are going to more developed countries. And this is really the graph that most people in healthcare care about. Asylum seekers are much more likely to be plugged into healthcare and insurance, and so you're much more likely to see an asylum seeker than a refugee. Mapped a little bit differently, you can visualize that asylum seekers are going to the US, South Africa, Sweden, Germany, and Turkey. These are incredibly challenging patients and cases. They're coming from a place where they have pre-existing medical conditions, as anyone might. So diabetes, renal disease, hypertension. On top of that, they have experienced war, trauma, persecution. Compounding that, they've had to deal with issues of migration and whatever comes hand in hand with that. When they arrive to a country, they face extreme stress from obtaining legal status and political asylum, extreme poverty. Most of these patients that I see when we do asylum evaluations, most people are homeless, they don't have cell phones. It's impossible to contact them, to get them plugged into the healthcare system. And when I say impossible, I mean it's very, very, very challenging. We do research with these individuals, and just contacting them to try to get them enrolled in some of our studies, our capture rate is like 5%. It's just so hard to get a hold of them on a phone. I want to spend just a few minutes sharing with you what our programs look like, and I'll start with an overview of some of the research that keeps my group really busy. It would be very hard to describe each of these research projects, but this is just a brief overview. My group takes a scientific approach to global human rights research. We're really, again, focusing on refugees, migrants, asylum seekers. We're studying, for example, early child marriage in refugee camps, violence against women in refugee camps, working with human rights databases to understand refugees and asylum seekers. We're investigating, for example, obstetric complications of female genital cutting abroad. Our group really functions like a basic science lab, so we have biostatisticians, we have faculty that have dedicated time, we have research aides, we have lab meetings where people present their work, and several of our faculty are involved with projects at the Weill Cornell Center for Human Rights. For my major project right now, I'm looking at chronic pain in refugee torture survivors. So torture leads to a combination of physical and psychological trauma, with some studies showing that chronic pain is prevalent in 83% of survivors of torture. A number of studies have actually looked at the types of torture and their specific pain sequelae. So, for example, falanga torture, which is beating of the soles of the feet, results in chronic pain, compensated gait, peripheral neuropathies. Palestinian hangings or suspension, arms tied behind the back and suspension from arms, results in pretty bad brachial plexus injuries. Hyperextension of the legs results in lumbosacral plexus injuries. And so people have sort of documented this, but there's been no clinical study in the US looking at refugee survivors of torture and what their chronic pain issues are. And so our group decided to take that on. And what we're looking at is the standard United Nations Istanbul Protocol that medical providers use. So refugees or asylum seekers are evaluated by internists or psychiatrists, primarily using the standard protocol. And while it does have some guidelines on how to assess pain, these are not specialists. And so what we were trying to figure out is how much of the pain is actually missed. And on interim analysis right now, I think we have close to 25 patients enrolled. But what we're finding is that there is a big difference in detection in pain from the UN Istanbul Protocol and a chronic pain specialist. As you can see here, the difference is at about 80%. We also implemented the use of the BPI, which is a validated pain screening tool, to see if we can use this and give it to general providers, like someone might use a PTSD screen or a major depression screen. And it's been interesting. People aren't really doing this research, so it's totally uncharted territory. But our findings are pretty striking right now. And this is how we're really trying to approach global health and human rights work, taking a more scientific approach. The only research studies that have been done have been narrative-based, and so that's not enough to provide changes and push for changes in evaluation and treatment, rehabilitation of these individuals. So we have a lot of research opportunities like this for our faculty and residents, but we're not just limited to research. So our multi-pronged approach really tackles education, research, and implementation programming, and I'll just very briefly touch on each of these. I wish I had time to go through all of these projects, but I don't. We have projects ranging from an undergraduate teaching course. which is a semester-long course for undergraduates at Cornell that we run through the anesthesiology department, bringing together clinical faculty from all throughout the medical college. We've created a digital, interactive, touch-based textbook on global health for all physicians, which was funded through a generous grant from FAIR and is going to be published and released April 24th. We have interactive educational sessions for residents and a residency global health research track for individuals who want to get advanced training. This was a session, an experiential didactic session that we did on refugee migration that was modeled after the game Oregon Trail, if anybody remembers that game, and was put together by one of our fellows. Our current fellow is actually a split global health and thoracic fellow. We have our standard, the electives abroad that people do. In our electives, it's a little bit different. So we do OR training and experiences in the OR, but we also do experiential didactics. So residents, when they go abroad to India or Rwanda, those are our two major areas, they spend only 50% of their time in the OR and 50% of their time meeting social activists, educators, leaders of NGOs to understand the social, economic, political, environmental forces that influence health. So there's a lot of opportunities for faculty, fellows, residents, medical students, undergraduates. One of the most frequent questions that I get is, why are anesthesiologists doing this? What role do anesthesiologists have? And one of my favorite things is to remind people of one of the most well-known anesthesiologists and epidemiologists of all time, who was John Snow. He was not only the first physician to study and calculate doses for the use of ether and chloroform for surgical anesthetics, but he also obviously became very well known for his discovery of the public water pump on Broad Street that resulted in the cholera outbreak in London. My point here, and my point throughout this talk, is really that anesthesiologists have a really vital and irreplaceable role to play in public and global health. I really think that we are healthcare providers first, physicians first, and anesthesia providers second. And so we really have so many different opportunities from global surgery, NGO participation, humanitarian disasters, research. We have not invested in these areas as a specialty, and I think there's a great opportunity to take a leadership role here and create an impact in this wide open area. And there's just so many different ways to get involved. And with that, I'll take questions. Sure. So initially, we were funded through our department. My chair is unbelievable, and we have a lot of support from the dean. And initially, our programs were funded through the department for 1 year, and then we received funding through FAIR, and then I received funding through the NIH. Our other faculty, so we have 4 or 5 other faculty that get dedicated global health research time. And our expectation is that people will be given support for a year or 2, and then they will apply for grants and be funded. Our fellow right now, who is finishing his fellowship and staying on as faculty, just applied for 9 grants. So January was a very rough month for him. We're really trying to take the approach that basic scientists take. I think global health can't be a hobby. It can't be something that people do in their spare time. Nobody would ever expect a bench researcher to do it in their spare time. And similarly, if we want to see results, if we want to really engage as an academic field, I think we have to invest in it the same way. So measuring how much goes into medical missions is incredibly difficult because there's no centralized agency to coordinate care. So people, Operation Smile, Operation Walk, whatever, everybody sort of does their own thing. And that's one of the really big problems. It's very hard to collect data. It's very hard to look at outcomes because there's just nothing centralized. So that is very challenging. What we do know is that people in internal medicine have been much more successful at getting funding because they've been able to create data around malaria, HIV, tuberculosis. And I don't know what the numbers are because it's impossible to measure what goes into medical missions. A lot of it ends up being volunteer time. So think about how expensive it is for us. The biggest cost is faculty time to go abroad and do work. And a lot of that ends up being volunteer work, which is why we've taken a little bit of a different approach. Our programs are actually focused more on US physicians. So if you can imagine a basic science lab where you have postdocs and you're training those postdocs how to do research and how to write papers. Our group, that's primarily what we do. So we train faculty, we train fellows, and we train our residents in how to do work in the developing world. A very small percentage of our programs, so I'd say about 15% of our programs actually involve the electives abroad. Otherwise, it's all research. So our fellow, for example, does almost no clinical work. I would say no clinical work in the developing world. Our fellow just learns how to do research, how to read papers, how to write papers, how to write a grant. And we expect them to get funding at the end of it. In terms of teaching people how to fish if you do go abroad, so that small percentage of our programs that do go abroad, it's very, very challenging because you have to really immerse yourself in the local culture and figure out what people need. So when we were in Rwanda recently, there was this independent physician who was teaching people how to do laparoscopic fertility treatments. And we were standing in the OR like, why are we teaching them how? This is not what they need. This is not what they're asking for. They need treatment for obstructed labor. I mean, thousands of women are dying because they can't access a C-section. But it's really about understanding what the local culture needs and what the local individuals need. And unfortunately, what that requires is a big upfront investment. So not necessarily a formalized needs assessment, but going in and figuring out what at the ground level is missing and how you could help. So an example would be anesthesiologists. One of the things that surgeons have been doing is because of this gap in C-sections, they're teaching technicians how to do spinal anesthesia so that they can increase the number of C-sections across the world. Now, it sounds like a great idea for the surgeons, but that is really, really dangerous. I mean, think about how much the rate of placenta accreta increases per C-section. And if a woman is expected to have 7, 8, 9, 10 babies, and they have no access to blood. So 20 years from now, what are the implications of surgeons teaching people how to do spinal anesthesia to increase the rates of C-sections? That's going to be a huge global health and public health problem. But anesthesiologists haven't really figured out what to teach, who to teach, how to participate in this process. It's really being driven by a whole different group of people.